before the muscle tightened, before the chambers moved blood. A small electrical impulse left the sinus node. The ECG did not draw the heartbeat or the sound beneath the chest. It drew changing voltage differences that organized the beat. The sinus node began the impulse, the atria carried it through. Their depolarisation formed the P wave, small beside ventricular mass. The signal reached the AV node, where conduction briefly slowed. The pause let atrial contraction complete, ventricular filling before the ventricles were told. And his unbundled branches sent the impulse rapidly down. Purkinje fiber spread activation through the ventricular walls. The larger ventricular mass depolarized, and QRS became the dominant trace. Electrical activation came first, mechanical contraction followed. Electrodes touch the body, each lead becomes a view. Each lead records a voltage difference along the angle it looks through. The heart performs one sequence, but 12 perspectives watch the tracing changes with the angle, though the event beneath is one. For depolarization, moving toward the positive pole of a lead. Toward rises, a wave falls across, stays small, often biphasic. The wave is magnet to the lead as direction. The paper writes their meeting. P records atrial activation. QRS records ventricular activation. T records ventricular recovery. The ECG does not draw the heartbeat. It draws the electricity that organizes it. From the start of P to the start of QRS, the PR interval spans the journey. Atrial activation, AV delay, and conduction toward the ventricles. The QRS records ventricular depolarization, brief when specialized pathways spread it fast. Atrial repolarization happens but hides inside that larger complex. After the QRS, the ST segment nears the baseline. Most ventricular cells remain depolarized, so little net voltage difference is recorded. The T wave is ventricular recovery. Electrical readiness being restored from QRS beginning to T wave ending. The QT spans activation and recovery. Not every tall wave means stronger pumping. Not every small wave means a weaker heart. Voltage is projection, muscle direction, distance, tissue placement, and timing. For depolarization toward rises, a wave falls across, stays small. One electrical event can rise in one lead, fall in another, and cross the baseline elsewhere. P records atrial activation. QRS records ventricular activation. T records ventricular recovery. Same heart, different viewpoints, electrical handwriting across the page. But recovery reverses the sign. A repolarization wave moving toward the positive pole tends to fall. Moving away, it tends to rise. Ventricular recovery often travels opposite to ventricular activation. Opposite direction, opposite electrical sign. So QRS and T can both be upright. And many normal leads do not memorize shape without direction. Ask what wave is moving, where the tissue activates or recovers, and which lead is watching. First confirm the paper speed and voltage calibration, then read and order rate, rhythm, axis, intervals, wave segments. When testing for sinus rhythm, does each P lead QRS? Does every QRS follow P? Is the rhythm regular? Is the QRS narrow or widen? Are the intervals normal or delay? Which direction holds the mean vector? Which leads see the same territory? The ECG can suggest rhythm disturbance, conduction delay, chamber enlargement, electrolyte effect, ischemia, up injury. travel, surface leads compared and paper ends. The beat had left a trace, not of the blood it moved, but of the electricity.